Good evening, everyone. How are you all? All right, everyone. So, new topic. We finished psychiatry. I hope you enjoyed our psychiatry session. So, tonight we're going to start with gynecology. Okay. So, let's move on. So, for gynecology and obstetrics, normally we will be following John Mottag. So, you can see John Mottag has a lot of chapters for gynae preparation, and that's more than enough for it. So, chapter 91 till chapter 99, all of these are gynae chapters. Okay, so we don't normally need to go to any other website, nor we need to go to even Kaplan Estate to seek it for gynae. So gynae has everything in Gen, and most of the time questions come within this topic. Okay, so let's start. So first one we're going to start with is chapter 91, which is cervical cancer screening. Very important for exam. So cervical cancer screening, as you understand, that this is done to make sure that you can catch cervical cancer in the earliest stage. And the idea of doing this screening is to make sure that patient don't get cervical cancer, rather we can get it in the initial stage. The primary cause of cervical cancer is HPV virus. So that's why the cervical cancer screening test mainly detects this HPV. There are almost 200 type of HPV, but 40 to 50 of them infect the anogenital area. And usually they are usually spread by skin contact during sexual activity. Now, not all the HPV are high risk for cervical cancer. Only these two, especially HPV 16 and 18, are responsible for around 70% of invasive cervical cancer and 50% of high-grade lesions. That's why these two HPV are called oncogenic virus. Now, prior to immunization, infection with HPV was common, mostly transient. So even though anyone can get HPV infection, almost 80% of women being infected with at least one type of HPV in their lifetime without even knowing it. So it's not that someone got a HPV virus and they have got a cancer. So anyone can get a HPV virus. Sometimes your body will be able to fight it within 1 to 2 years. But if there is a persistent infection with a high risk HPV, so if someone has got HPV 16 or 18 and persistently it's been there for years and years, it can gradually change. So first it becomes a low grade change, then it becomes high grade change, and then it progresses to cervical cancer. You can see here more than 99.7% cervical cancer are positive for HPV DNA. So this is usually the main cause. So most of the patient who develop cervical cancer is asymptomatic. If they are symptomatic, then they might be presenting to you with postcoital bleeding, that is the most important finding, intermenstrual bleeding, irregular bleeding, postmenopausal bleeding, or even sometimes kind of a bloody discharge or brownish vaginal discharge. So that's usually the presentation of cervical cancer, but postcoital bleeding is very important. So what is the screening recommendation nowadays? So in the past, let's say before 2017, we used to do 2 yearly pap smear. But from December 2017, the cervical cancer screening now has been changed to 5 yearly cervical screening test. So we no longer call pap smear, which previously we used to say. Okay, so we no longer use the term pap smear for cervical screening. Nowadays, the cervical screening program is what we call a cervical screening test, and that has to be done every 5 yearly for everyone. So what do we normally do in cervical screening test? In cervical screening test, we try to find out what type of HPV the patient has got. So that's why we do the HPV test with the genotyping. This test can identify the type of HPV patient has got, and it can say that if the patient has got HPV 16 or 18, which is oncogenic, or is it like a non-oncogenic HPV. So the test can identify the specific type of HPV. Okay. All women who have oncogenic HPV will have a reflex liquid-based cytology on the cervical smear. So what happens that first of all with the cervical screening test, you just find out what type of HPV patient has got. If patient has got oncogenic HPV, then you're going to, so you have already taken a sample from the cervix. So you're going to send it to the lab to look into any kind of cellular changes and find out like is it a low grade change or high grade change. Okay, so to check the cellular changes, we need to do this reflex liquid based cytology, or commonly known as LBC. So who usually we are going to screen? So women who are at 25 years or 2 years after their first sexual intercourse, which one is latter? So it's either patient can start from the age of 25 or 2 years after their first sexual intercourse, which one is latter? Okay. Both HPV vaccinated and non-vaccinated women will be screened. Just because someone has got Gardasil vaccine, which is for cervical cancer, doesn't mean that they don't need to have this cervical screening test. Anyone from the age of 25 up to the age of 74, they should have the cervical screening test every 5 yearly. If a woman over 75 requests screening, then you can do it. Otherwise, you don't need to. Always remember this is a screening test, which means you will only do this in an asymptomatic patient. For symptomatic patient, we are not just going to do this. There are more that we need to do. So women with postcoital or persistent intermenstrual bleeding will require a co-test. So co-test is needed for symptomatic patient. And co-test means you do both HPV genotype as well as you do the LBC. Okay. And once you do the co-test, now this is the tricky part. Let's say a symptomatic patient, you have got a patient who has postcoital bleeding. You have done the co-test, but it did not find any kind of HPV. Will you stop there? No. So even if their HPV comes back negative, still you need to send this patient to a gynecologist for colposcopy. Colposcopy is kind of looking into the cervix and taking a biopsy from the cervix to rule out any cancer. Okay, so that's called co-test. So co-test includes both HPV typing as well as a LBC. But even if co-test comes negative in a symptomatic patient, you need to send them for a colposcopy. One other thing, for women who experience their first sexual activity before the age of 14 and did not have HPV vaccine before their sexual debut, a single HPV test between the age of 20 to 24 can be considered. So this is the only time you can do it a little bit earlier. So there are some other group of patients. So let's say someone has hysterectomy. So in the hysterectomy, you remove the uterus. Do they need cervical screening? Yes. As long as they have got the cervix. So not all hysterectomy remove cervix. So cervical screening is still required if cervix was not completely removed. Okay. Pregnancy, can we do cervical screening during pregnancy? Yes. You can do cervical screening at any time during pregnancy. but you can't use this endocervical brush. There is an endocervical brush that also we use sometimes that cannot be used during pregnancy. For post-menopausal women, yes, we would do it. Now, this is important. For someone who is immunodeficient, like HIV, organ transplant patient, they need to be screened every 3 yearly instead of 5 yearly. Okay? So these are all good. Women with abnormal vaginal bleeding. Definitely, any patient who is symptomatic, you are going to send them for a core test. Women with postcoital bleeding or persistent unexplained intermenstrual bleeding require referral for colposcopy regardless of their result. So that's important. Women who has postcoital bleeding or persistent unexplained intermenstrual bleeding, even if their core test is negative, still they need a colposcopy. However, premenopausal women, so patients who are not menopausal, if they have a single episode of postcoital bleeding and you checked their cervix, which is normal, and negative core test do not need to be referred for colposcopy. So we say that the postcoital bleeding, even if core test negative, you send them for colposcopy. But there is a one group of patients who had it only once, normal cervix, negative core test. Then you can wait. See that if they're getting it again. If they get recurrent postcoital bleeding, then yes, you're going to send them. And any postmenopausal patient having a PV bleeding, you always need to be concerned because postmenopausal bleeding is always something red flag. Okay? Making sense for everyone so far? HPV genotype and HPV DNA are same. That's right, it's same. And Dr. Faria, so what you can do, you don't need for me to go to the last slide. You can open the portal and then open the file from the portal, and you can get everything in the portal. These notes are already uploaded. Okay, so for anyone who you think that we need to show you the slides, rather than doing that, you can always just open the portal and open it by yourself. That's easier for us. Okay. All postmenopausal women need screening or only with postmenopausal. All postmenopausal women need screening only. Yes, so postmenopausal women also will need the screening. So different thing. So postmenopausal patient is still there. If they're below 74, they will need the screening. So anyone between 25 to 74, they need cervical screening test. Okay. But when it is symptomatic, like postmenopausal bleeding, then yes, you are going to do all the investigations one by one. So we'll come to the postmenopausal bleeding later on, not right now. At the moment, think of postcoital bleeding, which is the main presentation of cervical cancer. Because the main cause of postmenopausal bleeding is endometrial cancer, which we will discuss later on. Okay, now this is very important. Cervical screening pathway. Cervical screening pathway comes in exam in a lot of ways. Now it might be a bit difficult for you to look. So again, you can open the portal and find it out. So cervical screening pathway, first of all, let's say this is an asymptomatic patient and patient had a cervical screening test. The first thing that we are going to do is HPV test with genotyping. When we do the HPV test with genotyping, the genotype will give us two things. One, that it is HPV detected, but it's not 16 or 18. So it's a non-oncogenic HPV. Or it can say HPV detected, but it is 16 or 18. So it's an oncogenic one. It can say it is unsatisfactory. That means maybe you haven't done it right. So the result is unsatisfactory. Or they can say there was no HPV detected. So these are the four possibilities that can happen. If it says HPV not detected, then patient will go for 5-yearly screening. Okay. If it is say unsatisfactory, then you need to do the repeat test in 6 to 12 weeks time. So these are two easy things. Now come back to the main thing. What if patient had a non-oncogenic HPV, which means not 16 or 18? Whenever you detect a HPV, you do the LBC. That means you check the cellular changes. The cellular changes can be either it is a low-grade squamous intraepithelial lesion, so LSIL, or it could be high-grade squamous intraepithelial lesion. So it is either LSIL or HSIL. So we did the LBC, and LBC says it is unsatisfactory. Anytime it is unsatisfactory, you need to do a repeat test in 6 to 12 weeks time. LBC shows either there is no cellular changes or there is only low-grade changes. So either negative or LSIL. In that case, you need to do the repeat test in 12 months time. Okay? So let's say you have done it after 12 months. Again, you have detected HPV, but it is still not oncogenic. So after 12 months, you again got HPV. So you did LBC again. Now this time, patient again got LBC showing negative or LSIL. Okay. Then you do another repeat in 12 months time. So see that how many, like we're just doing it multiple times. So first you have got LSIL or negative. So you did a repeat. Again, you have got HPV. Again, it is LSIL or negative. So you did a second time repeat. After second time repeat, if still you got HPV, whatever is the HPV, doesn't matter, that patient will go for colposcopy. So after second repeat, if you get HPV, then that patient will require colposcopy. And after second repeat, if there is no more HPV, then you just go for routine 5-yearly screening. I will come to this just after a bit. Now, is this clear for everyone? This line, like how we did this part? So don't ask me to repeat it again, like after finishing the whole thing, because it will be difficult. So if you need me to repeat now, I can. All good? Okay. So we say that if you did, let's say that first time you have got, so you have got HPV, but not oncogenic. So you did a LBC. LBC shows it's negative or just a low grade change. So you do a repeat again in a year. After 1 year, still it is HPV detected, but non-oncogenic. Then again you have got it is negative or LSIL. So you do second time repeat. After second time repeat, still HPV there, you send them for colposcopy. Now, let's come back to the first time. You detected a non-oncogenic HPV, but when you did the LBC, it found high-grade changes. Any high-grade change will require colposcopy immediately. There is no repeat. So high-grade change, you send them for colposcopy. The first time when you have done the HPV, it detected an oncogenic HPV, 16 or 18. That one, also will go for colposcopy. Okay, so this is not hard. So either anytime you get high grade change or you get an oncogenic HPV, that patient will require colposcopy immediately. Okay, now I told you that there is a little bit of things in here. So you have done first time repeat and you still got HPV and still LSIL. So before second time repeat, now after first time repeat, there is few patients where you need to go direct colposcopy rather than repeating it in a year time. So those are the women who are above 50 year, Aboriginal Torres Strait Islander, and women who are overdue for screening by at least 2 years. So these three group of people, you can only repeat once. Even after one repeat, still HPV there, and still there is low grade changes, you send them for colposcopy. Okay. So if you want to just print it out, this is the link of that guideline that we discussed. It's a very, very important. Questions come from here in a lot of different ways. So you need to memorize it ins and out. Okay. All right. So in here, they have given a table of all the things that we discussed. What is the post-treatment assessment of HSIL? So some of the patient who develops HSIL, they will require treatment. What kind of treatment we do? So let me discuss a little bit, but in question discussion class, we will discuss more. So if someone has got HSIL, for HSIL patient, our treatment could be ablative treatment. Okay. So you can either do an ablation by cryotherapy, heating, coagulation. So lots of ablation procedure is available. And then the other one is excisional procedure. And commonly, we prefer the excisional procedure. In the excisional procedure, mainly we go for lip, or we call it LLETZ. So in lip or LLETZ, what we do that we use a loop of wire, which is like an electric wire, and we just remove the part of that cervix which is showing the HSIL. Okay, so LEEP means loop electrosurgical excision procedure. So in LEEP or LLETZ, same thing. So in LEEP, we just use a wire heated by electric current and we remove that abnormal part. So LEEP is the most commonly used procedure for HSIL. Okay. For LSIL, normally we don't treat them. We allow the body to fight. That's why you do this repeat 2 times. Okay. But for HSIL, once you do the colposcopy, and if colposcopy says no, it is not a cervical cancer, then you'll be treating them as like LEEP or LLETZ. The other excisional procedure is cold knife conization. Cold knife conizations are also done sometimes, but it is not usually the most common one. Okay, so we'll discuss about this a little bit more in our question solve class because we do discuss some questions related to this. Practically, we do the lip. Okay, so lip is the common procedure which is normally done. So once you have done the lip, patient should have a test of cure to confirm that the treatment has been successful. So test of cure is a core test performed 12 months after the treatment. annually thereafter until patient receives a negative co-test on 2 consecutive occasions. So once you treat the HSIL, you need to do another co-test in 12 months time, and then until patient has got a 2 consecutive negative co-test, patient has to do it every year. Okay, so that's post-treatment assessment of HSIL. HPV vaccination. So in Australia, there are HPV vaccination given to everyone. So currently, the Gardasil vaccine is administered through the National Immunization Program to male and female aged 12 to 13. So everyone who is school going, we normally give them Gardasil vaccine. So male and female. Okay. Any question, guys? And Dr. Shuha, that's right. So everyone, the, I haven't mentioned that, but reflex LBC is done for everyone who has HSIL, or like before colposcopy, everyone will have like a LBC. That will be common. And this one is the guideline that we will follow, Dr. Sana. I don't know what is in the red book, or red book actually does it have it or not, but the one that we are doing now, that's the newest guideline. No, for no, like you don't need to ask the patient to come back for a LBC, because the sample that you take, they can do the LBC on that same sample. So patient, you don't need to do it twice. Because male can get HPV and they can get anogenital wart from HPV. Yes, I think the screening chart is available in JM. So you can open up the JM. So it's in 91 chapter. If lesion is beyond the cervical canal, as I said, we will discuss this a little bit more in our question solve class. But yes, if lesion goes into the cervical canal, then cone biopsy is the treatment, or cone biopsy is the procedure that we do. Okay, that's all about the cervical screening. Moving on to our next chapter, family planning. Now, family planning, although it is very important, but it can be quite boring to go through because all you need to do is to memorize. Okay, so I can't help you too much to memorize these things. You have to do it by yourself. So I can only show you what are important from here. Okay, so this is the chapter, I think 92. Yeah, so chapter 92 from JM. So family planning or contraception is an important topic from gynae. So you know that there are hormonal method of contraception, non-hormonal method of contraception. Non-hormonal, we will discuss it later. Hormonal method of contraceptions are two types. One is combined estrogen and progesterone, and another is just progesterone. Progesterone only contraceptions, there are several type of this. So it comes as pill, which is progesterone only pill known as mini pill. Then it comes as subdermal implanon or implant, then intrauterine device like Mirena, and then also sometimes injectable ones. So these are the four methods of progesterone only contraception. This method is safe in women who are breastfeeding or who has contraindication to take estrogen, because you can't give COCP, which is combined oral contraception, to patient who is breastfeeding. And also there are lots of contraindication of estrogen. So for those patients, progesterone-only methods are commonly used. But progesterone-only contraception is also contraindicated in women with active breast cancer within the last 5 years. So try to memorize this, because with a active breast cancer in the last 5 years, you will not be able to give anything to them, not COCP, not progesterone-only contraception, because both are contraindicated. Good thing about progesterone only contraception is that it's not associated with increased risk of thromboembolism. So patient who has history of multiple DVT or PA, for them you can't give estrogen. For them, progesterone only contraception is good. Same, women who take liver enzyme inducing drugs are not advised to use POP, which is a progesterone only pill, or Implanon due to reduced effectiveness. So not everyone can take progesterone only contraception, especially if someone taking liver enzyme inducers like rifampicin, okay, then let's say carbamazepine. So there are lots of common medication who are liver enzyme inducing drugs. For those patient, you can't use POP or Implanon. For them, the best to use is DMPA or levonorgestrel IOD, which is Mirena. Okay, so if a patient is on liver enzyme inducers and they're asking you that what is the best contraception for this patient, that will be these two. Okay, now let's start one by one with all of these contraceptive methods. For this contraceptive method, you need to know that, like, what is the contraindication of this, and what are the effectiveness, and what are the common side effects of this. Okay, that's usually what you need to remember. So first, Implanon, which is a subdermal contraception. That means you just insert this kind of a rod-shaped thing, which you insert under the dermal, like means under the dermis. So this subdermal contraception, it's a 3-year contraception, which only contains progesterone. The most common side effect is irregular bleeding. Okay, and 1 in 5 experience prolonged bleeding also. Okay, so few gets irregular bleeding, few gets like prolonged bleeding, few get no bleeding at all. So any of these three can be the side effect of Implanon, but the most commonly irregular bleeding is the side effect. 22% of women become amenorrhea, that means no period at all over 12 months. Now, there is the only contraindication is the same contraindication for progesterone only method. So it's the same for every progesterone only method. So active breast cancer, you can't give them Implanon. Pregnancy rate is the lowest of all contraceptives at less than 1 in 1,000 over 3 years of use. So this is one of the mostly effective contraception. All right. So that's Implanon. Intrauterine device. So intrauterine devices are also commonly used. These are also very effective, longer acting, reversible contraceptive, LARC, and it can be used in women in any age group, not just like older patient. You can use this IUCD in young and even in nulliparous women. So there is a idea that nulliparous women who don't have any kids cannot have IUCD. It's not like that. Young nulliparous women can also have it. All right. So there is no problem with using IUCD for a nulliparous women. There are commonly two types of IUCD that we use. One is copper IUCD, which is no longer very commonly used. The common one nowadays is this Mirena, levonorgestrel IUCD. So what are the absolute contraindications? If someone has got active pelvic inflammatory disease, undiagnosed vaginal bleeding or genital tract bleeding, and a current or past history of breast cancer. So these are the absolute contraindication where we can't use IUCD. Copper IUCD gives 5 to 10 years protection, and Mirena gives 5 years protection. Side effect. The biggest difference between copper and Mirena is the effect of bleeding. Remember, women who use copper IUCD, most of the time they have increased bleeding. It means they get more bleeding after using them. That's why it is not very commonly used, but it gets better within 3 to 6 months. Whereas if you use Mirena, it causes reduction of blood loss. So that's why it is one of the most commonly used hormonal contraception for patients who suffer from menorrhagia, like excessive menstrual bleeding. Okay, so that's why it is more favorable. 65% of women become amenorrheic only after the first year of use. So menstrual bleeding and pain is the most common side effect for IUCD. There are few other side effects which we are going to discuss. If a patient, now it is highly effective, but it's not like 100% safe. No contraceptive company says that it is 100% safe. So there is always even a slightest chance is there that they can get pregnant. So if a patient get pregnant while they use IUCD, there is an increased risk of abortion and intrauterine sepsis. So that's why if a patient who is on IUCD got pregnant, you have to remove the IUCD as soon as possible. And also patient who gets pregnant on the top of IUCD use, chances of ectopic pregnancy is very higher in this patient. Okay. And also there is a small increased risk of pelvic inflammatory disease in the first 20 days after insertion of this IUCD. That's why it is contraindicated in a patient who has active PID. Sometimes it can just spontaneously it can get extruded. Sometimes, very rarely, it can even cause perforation of the uterus. So perforation is not very common, but it can happen. So if a patient who is on IUCD complains of abdominal pain, you have to think of that if IUCD has perforated the uterus. So if you can't feel the thread, so IUCD usually will have a thread which you would be able to feel in the vagina. So if IUCD thread is not palpable or missing and patient complaining abdominal pain, then you need to rule out perforation. So what you do in those cases, you can do a X-ray and then pelvic ultrasound, because X-ray and pelvic ultrasound will be able to say where exactly is this IUCD. Okay, so it's not very common, but you just remember that these can happen. IUCD does not cause ectopic pregnancy. So this is a mistake a lot of people has, that IUCD will cause ectopic pregnancy. It's not like that. It's like this, that if a patient gets pregnant while using IUCD, then chance of getting ectopic pregnancy is higher. All right? But it's not like that a patient using IUCD and then you remove the IUCD, but still they will have increased risk of ectopic pregnancy. It's not like that. Okay? So far clear, everyone, with the implanon and IUCD? Okay. Moving on to injectable contraceptive. The injectable one means you just give them injection. So this is called DMPA, dipomedroxyprogesterone acetate. It is the only injectable intramuscular contraception available in Australia. It is only effective up to 3 months or 14 weeks. So patient needs to come to you every 3 months to have that injection. Otherwise, it will no longer become effective. Now, all the others like Implanon, IUCD that we have discussed, those gives long-term protection. One 3 years, another 5 years. And if you remove them, patient will immediately become fertile again and they can fall pregnant. But DMPA has this problem is that if you remove them, it's not immediately reversible. So it can even take 18 months for some patient to get their fertility back. So it is not a good contraception for someone who says that, doc, I want to have contraceptions for 3 years, but after 3 years I have a plan to have a baby. Okay, so if that is the plan, like they have an exact plan, like no, after a year we're going to have a baby. So for those patients it's not good because they have a specific plan, and most likely it is not going to be, it can get complicated because if you remove them, then they might not be immediately fertile again. Okay, so for someone who understands this, then you can give it to them. Otherwise, don't go for it. And it is not the first line contraception. The first line contraception would be either COCP or any of these like Implanon, or you can give progesterone only pill like mini pill, and then IUCD. But DMPA, you can say it is the least likely answer in your exam. So side effect is it can cause amenorrhea, 50 to 70% by 12 months, weight gain, breast tenderness, mood changes, and delay in return in fertility. And it is not a first-line contraception for women less than 18 or over 45, because if you use it for long term, it can cause accelerated bone loss. Okay, after DMPA, we have mini pill or POP. So POP is also very commonly used. It's mainly commonly used for breastfeeding mother who still wants to continue some pill. So for breastfeeding, POP is very commonly used. Okay, and it is safe from 6 weeks after delivery. So it has also very good efficacy, 99.7. And sometimes only problem can be that it can cause irregular cycle. Okay, so that's all the progesterone only method of contraception. Now we move on to combined hormonal contraception, which has estrogen and progesterone both. So it is one of the commonest contraception that's used in Australia. So they are available as oral contraceptive pill or COCP or also vaginal ring. Both has similar efficacy. Everything is same. Okay, it's just how they use it. So there were times when people used to take high dose estrogen. Nowadays, we don't give high dose estrogen to anyone. There are very small proportion where we go for high dose estrogen, but most of the patient will have a low dose or a moderate dose of estrogen. So low dose is 20 microgram, and then usually the common dose that we use in Australia is this 35 microgram of ethinyl estradiol. The reason is that the higher the dose that you use, higher the risk of complication. So if you use high dose estrogen, the patient has a high risk of venous thromboembolism. So formulation containing 50 microgram or more, they are no longer recommended. Women starting on a 20 microgram ethinyl estradiol are likely to have fewer hormonally related side effects. But if you use 20 microgram, then they have an increased risk of breakthrough bleeding. So it will not cause that much of a hormonal side effect like headache, mood swing, but low dose can cause more breakthrough bleeding. So 35 microgram actually balance everything. So it doesn't give that much of a hormonal side effect. It doesn't give that much of a breakthrough bleeding. So that's why it is the recommended dose. So starting the COCP, the suitable first choice is a monophasic pill containing 30 microgram or 35 microgram of ethinyl estradiol with a levonorgestrel or norethistron, which is the progesterone. So lots of common pill is there like microgynon, monofim, Levlan. So these are very commonly used in Australia. Okay, so this is the first line. So first line is COCP, which has 30 to 35 microgram of ethinyl estradiol with a progesterone. So some of the specific patient group like acne and hirsutism, the estrogen in any hormone like any COCP can improve acne and hirsutism. But the COCP which has anti-androgenic progesterone, they are better to be used in a patient who has acne. So let's say a young patient coming to you, they want hormonal contraception. And you have come to the idea that you want to give them COCP. You have also found during your examination that patient has got acne, right? So for that patient, if you go for a COCP, choose a progesterone which has anti-androgenic property. Okay, so that's one of the best way because it's going to help the patient in both ways. Women over the age of 35. So you can use combined oral contraceptive for a healthy non-smoking women until the age of 50. But it is not recommended if women is over 35, has multiple cardiovascular risk factor, including obesity, smoking, diabetes, hypertension. Very important. So you can use COCP up to the age of 50 if patient is healthy, no cardiovascular risk, non-smoker. But if they have more cardiovascular risk, then after 35, it is no longer recommended. Second, women who take liver enzyme inducing drug. It is strongly advised not to give COCP if a patient is taking liver enzyme inducers, because the only hormonal contraception that usually is effective with these medications is DMPA or IUCD. So you can see that some of the liver enzyme inducing drugs are carbamazepine, phenytoin, St. John's worts. Okay. Now this comes in exam. For women who still request the use of COC, an extended regimen of a higher dose pill containing estrogen 50 may be effective. So this is the only time where we can go for 50 microgram estrogen in the COCP. Okay, so let's say you have got a patient who is on a drug which is liver enzyme inducers, and patient wants to continue the COCP. First of all, you will say that it's good idea to choose something from DMPA or IUCD. But patients say, no, I want to be on the pill. So in that case, go for a higher dose of COCP, which has at least 50 microgram ethinyl estradiol. Okay. So this is important. You have to memorize this table, contraindication of COCP. So that's called MEC4, which means absolute contraindication. So absolute contraindication, first 3 weeks postpartum, more than 35 years and is smoking more than 15 a day, history of thromboembolism like deep vein thrombosis, pulmonary embolism, cerebrovascular disease like someone who had a stroke or mini stroke, ischemic heart disease, uncontrolled hypertension, complicated valvular heart disease, cardiomyopathy, migraine with aura, breast cancer, genital tract cancer, severely impaired liver function. Okay, so any of these are absolute contraindication to use COCP. The easiest way to remember is Someone who has got cardiovascular or cerebrovascular problem, you can't give them COCP. Okay, because most of these are cardiovascular and cerebrovascular. There are some relative contraindication also. It's case by case we decide. Better not to give it, but it's not like you can't use it for relative contraindication. So what are the beneficial effects of COCP? The beneficial effect is that it can reduce the menstrual cycle disorder. So if someone has painful period, heavy menstrual bleeding, COCP can help with that. It can reduce the incidence of ovarian cyst and benign ovarian tumor. It also reduces the incidence of ovarian cancer and endometrial cancer. So it comes in exams, so remember it. It reduces acne. You can use COCP to manage PCOS. It can also help with PMS or PMDD. Can reduce the risk of bowel cancer. So 3 cancer, it can reduce the incidence. Bowel, ovary, and endometrium. Okay. So what are the side effects? The most common side effect is, like, most of the time patient can have bit of GIT upset, breast tenderness, mood swings. Those are common. But the major side effects we already discussed. So deep vein thrombosis, PA, it can increase the risk of heart problem, stroke. Okay. So COCP and cancer, it comes in exam. So it can increase the risk of breast cancer and cervical cancer, but it can reduce the risk of these 3 cancer. And in this table, they have also discussed that how to manage common side effect of COCP. So you can go through it in your own time. So one of the things that if a patient coming to you who is on COCP and having increasingly breakthrough bleeding. So if they get a lot of breakthrough bleeding or heavy breakthrough bleeding, first find out that what's the dose of estrogen they are taking. If they're taking 20 microgram estrogen, increase the estrogen to 35. That might help sometimes. If they're already on a 35 estrogen, then change their progesterone. Okay. So breast tenderness, you can reduce the estrogen or progesterone dose. So in this way, you can go through this a little bit. It's not very commonly asked, so just read it. Some of the important advice for the patient. So if a patient gets diarrhea or vomiting within 2 hours of taking an active pill, they need to take an additional active pill. So if a patient takes a pill and within 2 hours they vomit, they need to take another pill. All right? Missed pill. Now this is where you will get crazy and it will be a bit complicated. So missed pill comes in exam. So what is missed pill? Missed pill is defined as one that is taken more than 24 hours late. So first of all, let me discuss how this actually works. So COCP, ideally, it has 21 active pill and 7 placebo or inactive pill. And in this placebo pill, sometimes there will be sugar, sometimes there will be iron, okay, but those are not hormonal pill. So once patient starts this non-hormonal pill, they get their bleeding. Okay, so that's withdrawal bleeding. So 21 active pill and 7 non-active pill. That's how usually they need to take it. And they need to take 1 pill every day to be effective. What if they miss a pill? So we only say missed pill if the last pill was taken more than 48 hours ago. So more than 48 hours since the last pill was taken. Okay. So if that is the case, take the pill most recently missed straight away. And it can mean taking 2 pills in one day. but you don't take more than 2 pills in a day. So if you miss more than 2, then you just discard the rest of it. And advise the patient to use condoms for 7 days. So let's say if a patient missed the pill, means that their last pill was more than 48 hours ago, then you advise them to take the recently missed pill and also today's pill. And then use condoms for the next 7 days. But if it is no, that means the last pill was not taken more than 48 hours ago, then you just ask the patient to take the pill straight away. So it might mean that patient just need to take 2 pills in 1 day. And you don't need to advise the patient to use condom for 7 days. Now, this is the complicated part. So let's discuss. Fewer than 7 pills taken since the last placebo break. So let's say this is the, so 1, 2, 3, 4, 5, 6, 7. So this is the active pill. So this is 3 weeks of active pill, and then the last week of inactive pill is this one. Okay. So they said fewer than 7 pills taken since their last placebo break. So this is the placebo break. After the placebo break, again the new active pill will be started next month, right? Now let's say fewer than 7 pills taken. So after this break, let's say patient has missed the pill over here. So definitely patient did not take more than 7 pills since the last placebo break. Does it make sense for everyone? That what does it mean? Fewer than 7 pills? So we're saying that these are the active pill. So 3 weeks of active pill, which means 21 active pills and 7 placebo pills. So this is 7 placebo pill. And then again patient will start their active pill. So the question is fewer than 7 pills taken since their last placebo break. So this was their last placebo break. And let's say patient has missed this 2 days pill. So definitely there is fewer than 7 pills that patient was taking before the last placebo break. So if this is the case, then you need to ask the patient to take an emergency contraception if they had a unprotected sex in the past 5 days. Okay, so consider levonorgestrel emergency contraception if unprotected sex in the last 5 days. Okay, now there is one scenario. The another scenario is fewer than 7 pills left before the next break. So this is the placebo break. Let's say patient has missed over here. So how many pills left before the next placebo break? Guys? 2, right? So that means fewer than 7 pills left. So if there is less than 2 pills left, less than 7 pills left before the next placebo break, in that case, you ask the patient to skip this placebo and continue with the active pill. Okay? That means there is 2 scenarios. One, that if a patient miss pill in the 3rd week or 1st week, that's the time there is this 2 problem. If they miss it in the 3rd week, then they need to skip the placebo break and continue the active pill. If they miss it in the 1st week, then they need to consider emergency contraception. That's the easiest way to remember. Okay, clear everyone? I don't think I can repeat this. Great. And they have also written in a very good way over here. That's also much better. So you can see they have written in here. You can read it also if there is any concern. Yeah, they will miss the withdrawal bleeding if they don't take the placebo, and that's fine. So this is emergency contraception. There are lots of emergency contraceptions are there, so you can just remember the name of them. So emergency pill is on the top of the active pill. Patient will continue the active pill as they are doing. An emergency pill is just like you just need to take one, like one emergency contraception. Okay. So it's not going to change anything. Patient will continue taking everything. Emergency contraception is a different kind of pill. Continue active pills for how many days? Which one, Dr. Tawhid? So it will just go on and on. So you will skip the placebo and then you just jump from here to here. So then you will continue the active pill first week, second week, third week, and then you will get a placebo break on fourth. Okay. So now, as I said, there are some non-hormonal methods as well. So it also comes in the exam. So there are non-hormonal method of contraception, like you can find out the basal body temperature method. So they say that coitus should occur only after there has been a rise in basal body temperature of 0.2 degrees Celsius for 3 days. Okay. So when ovulation happens, during that time, there will be a slight increase of basal body temperature. So for that 3 days, if someone has intercourse, they have high risk of getting pregnant. So they just need to make sure that once this 3 days is gone, then they can have a safe intercourse without thinking that they can get pregnant. So that's basal body temperature. Calendar method, also it comes in exam. To check the calendar method, you need to first find out what is the shortest and longest cycle patient usually gets. So if a patient says, like, normally my period is from 28 to 35 days. Okay. So to find out that what is their safe and fertile days, you do subtract 21 from the shortest cycle and 10 from the longest cycle. So what it becomes? So 7 till 25. Okay. So for this patient who has their cycle 28 to 35 days, their fertile days are from the day 7 to day 25. Okay. So during this time, there is an increased risk of getting pregnant. So any days before or after is safe days. Okay. So for calendar method, you find out what's their shortest cycle and what's their longest cycle looks like. From the shortest cycle, you subtract 21 and from the longest cycle, you subtract 10. So you can see it is 7 to 25 days. So we're talking about a cycle, right? So 7 to 25, this day patient is fertile. So chance of getting pregnant is high if patient has unprotected sexual intercourse. So safe days will be anything before or after these days. Okay. Then there is Billings ovulation method. Billings ovulation method is just, it's kind of like a keeping a record of sensation of their vulva and their mucus. It says that once patient gets into the fertile phase, they usually get like a bit of change in their mucus. So mucus starts to become more lubricative. So when ovulation happens, the the women can feel that the mucus becomes more slippery and lubricative. And then once the fertile days is over, then again it's no longer slippery. So the peak day of fertility is the last day of the slippery sensation, with or without the visual appearance of the mucus. So it says that the peak day of fertility is the last day of the slippery sensation. The post-ovulatory infertile phase begins on the 4th day after the peak day. So try to understand. It's very difficult, and no one usually will be able to check all of this, but this is one of the methods. So in Billings ovulation method, the peak day of fertility is the last day of slippery sensation. So from the last day of slippery sensation until 4th day, this time is the highest risk of being fertile or being pregnant. So after 4th day, then the infertility phase begins and it is safe to have sexual intercourse. Okay. Then there is lactational amenorrhea method, and there is mainly for patients who breastfeed exclusively. They can also have, like, they also have a less risk of being pregnant. But lactation itself is not a reliable contraception. So that's why, along with, even if they're exclusively breastfeeding, we say that there should be some other form of contraception, such as progesterone only pill. Okay, so that's all about the family planning or contraceptions. It's a very important chapter. As you can see, a lot to memorize, so you just need to go through it in your own time again. Okay, cool. We're going to take a 10-minute break now, and then we will start with some other topics. Any questions, guys? Okay, so let's take a 10-minute break. All right, everyone, let's start again. Okay, so the question you asked about, yeah, so usually 6 weeks after delivery, we start the contraceptions. Okay, so we will we will not discuss breast pain today. We'll move on to some other topic. So breast pain and breast lump we will discuss in our next class. All right, so we are going into this one, lower abdominal pain chapter, which is super important for exam. So let's start that. So lower abdominal pain in a reproductive age group patient. So it can be due to a huge amount of causes, right? So first topic that we are going to discuss is ectopic pregnancy, because ectopic pregnancy should be ruled out in any reproductive age group patient who is coming to you with a lower abdominal pain. So who are the patient at risk? Definitely patient who had previous ectopic pregnancy, history of PID, and endometriosis, IVF. These patients are also in a risk. So what are the symptoms of ectopic pregnancy? So first of all, patient will come to you with missed period, so which means secondary amenorrhea. So missed period, and then patient comes to you with a lower abdominal pain. So it can be right or left iliac fossa pain, and plus or minus they can have a PV bleeding. So these are the main three symptoms: secondary amenorrhea, that means missed period, followed by right or left iliac fossa pain, and it's not always that they will come to you with a PV bleeding, but they can come to you with a paravaginal bleeding. So that's the main three symptoms. Apart from that, if a patient has got a rupture ectopic patient will have a excruciating pain. So that's the difference between pre-rupture versus rupture. Pre-rupture will not have that much of a severe pain, but when it is ruptured, patient will be in a severe pain, and most importantly, they will be in a circulatory collapse, which means they will be in shock. All right. So this is what we said in the clinical features: secondary amenorrhea, lower abdominal pain, PV bleeding. If you examine this patient, you will get tenderness in the iliac fossa. Vaginal examination, patient will get cervical motion tenderness. You can also sometimes, if the ectopic pregnancy is in the tube, then you can get palpable adnexal mass or adnexal tenderness. And sometimes you can even get a prune juice appear PV bleeding. But most importantly, you get tenderness in the iliac fossa, and you get cervical motion tenderness or adnexal tenderness. So when you suspect that someone might have a ectopic pregnancy, what would you do next? So first thing is you are going to do a urine pregnancy test, because you need to confirm that if the patient is pregnant. If urine pregnancy test is positive, the next thing you do is to do a serum beta HCG. So serum beta HCG will be able to say that what could be the week of pregnancy. That means what is the gestational age of pregnancy. So it's very important to understand that an ultrasound will not be able to find out if there is anything in the uterus until it is 5 to 6 weeks. So that's why if we are not sure that when was the last menstrual period, then we do a serum beta HCG. And serum beta HCG, according to the new guideline, if it is more than 2000, then an intrauterine pregnancy should be visible on a vaginal ultrasound. So you do a beta HCG, and if beta HCG comes more than 2000, then you send the patient for a ultrasound. And if ultrasound says that there is nothing inside the uterus, that's ectopic pregnancy. because by the time the beta ECG is above 2000, ultrasound should be able to see if there is anything inside the uterus. By anything, I mean that if there is a livable or a viable pregnancy. If uterus is empty, then ectopic is more likely. If less than 2000, then you can't do an ultrasound. So all you can do is to do a repeat beta ECG every second day. So we say that every second day, beta ECG should be at least more than double in a normal intrauterine pregnancy. So if it is not more than double, then you can suspect that yes, it could be an ectopic as well. Again, making a little bit sense. So you suspect a patient to have ectopic pregnancy. You did urine pregnancy test, it came positive. So patient is pregnant. Now the question is it ectopic or intrauterine? So you do a beta ECG. Beta ECG came more than 2000. So it means that now you can do an ultrasound, and ultrasound can confirm your diagnosis. But if it is less than 2000, then ultrasound will not work. So then you do a serial beta ECG every second day. And ideally, if it is intrauterine pregnancy, then beta ECG should be doubled every second day. So if it is not doubled, that means it is not a normal intrauterine pregnancy. So what it is? Ectopic pregnancy. Okay? The best way or definitive way to confirm the diagnosis is laparoscopy. But that's usually not needed. You can follow this process and you can easily diagnose ectopic. Yeah, if urine pregnancy test is not like the best test, so if you still your urine pregnancy test came back negative, but you still suspect ectopic, yes, you will go for a beta ECG. Then beta ECG is a blood test, so you can't just do it like you don't get a quick beta ECG result. So urine test, it's quick, but because beta ECG is a blood test, so you need to wait. Management. So if you confirm that this is a ectopic pregnancy, next thing is that is it a unruptured or ruptured ectopic? In case of a ruptured ectopic, you don't have any time. You need to take the patient to the emergency operation theater for salpingectomy, which means that you need to remove the ectopic and then also you need to remove the tube. If it is an unruptured ectopic, then there are two options. One, that you can go for medical treatment or surgical treatment, and very small number cases expectant management, like just wait and watch. Medical management involves injecting intramuscular methotrexate, and sometimes this methotrexate can cause resorption of the ectopic. And surgery is mainly salpingostomy. Salpingostomy means with a keyhole surgery like laparoscope, you just do a small cut on the tube, remove that abnormal sac, and then repair the tube. That's salpingostomy. All right. So salpingostomy in a unruptured ectopic, and in ruptured ectopic, you need to go for salpingectomy. So once a patient gets ectopic, the subsequent risk of ectopic pregnancy is 10 to 15%. So remember that it comes in exam. So that's all about ectopic pregnancy. Okay. Next. Ruptured ovarian follicle or Graafian follicle.